worldwide. Number one, they are still causing a lot of mortality. Okay, malaria only cause 3/4 of people dying, and then they cause a lot of morbidity, and we measure morbidity by DALYs, which is disabling years of life. So that is important part. Secondly, we talked about migrant tropical diseases, because now we are seeing a lot of tropical diseases in the Western world, and so people are moving, and people are now complaining. If you go to America, you can find Chagas disease, which is a cause of heart disease, and unless you think about Chagas disease is a trypanosomiasis of South America, causing heart disease. If you don't have it in your mind, then you may miss some cases of heart disease in the States. So that is the scope of tropical diseases, which need to cover and need to see how we can get through. It's a big subject, big course, but let us see what are the important parts of tropical disease, which every student should know. It's good that you are in a tropical countries. Tanzania and Rwanda are in tropical countries, and some of our students fell ill with malaria, so that at least they know what sort of diseases they can encounter. We tagging infectious disease and tropical disease together so that we can cover the important diseases, because there is an overlap. All right, one point which you always need to know when you are working in Africa is HIV/AIDS. Because once you have immune compromised status, then everything change. Everything change. If you are not prone to develop certain fungal disease like cryptococci, then you will develop it. Okay, infection is very severe, and so on. I mean, the appearance of tumors like Kaposi sarcoma has emerged in Africa because of HIV/AIDS, Kaposi sarcoma. So anyway, always think in the background of HIV/AIDS. Now, the way I'm going to tackle the course in tropical disease by giving you cases, and we go through the case. I intend to send the case immediately after I finish my lecture now. I send you the new case. I give you 3 days to look into the case and try to answer the questions which are attached to the case. Then think about it, and I always prefer that the student should write the answers, either by take a pen and paper or a finger and a keyboard to answer the questions. Because once you answer the question in writing, you remember what you did. So in the last 2 days of the week, I will send you the answer. I would like to come to the next tutorials or next lecture, having had the answers, so that I can discuss the case in a more elaborate way. So the first case you remember was a young man from Marawi, and geographical location is important in tropical disease. So he is from Marawi, and we know what diseases are there. Okay, he came with symptoms. Some of the symptoms made an alert, or what we call red flag. Okay, he came with fever. You with me? Hello, are you hearing me?
Yes.
Okay, so he came with fever, and the fever is almost subacute. It's 10 days. All right, so it's not like an acute fever and then confusion. So he had fever for 10 days, and then he started to have headache. Okay, the headache is severe, and the examiner is putting occipital site for the headache. He also indicate that this is maybe some irritation of the meninges. Okay, The thing is that he started to have confusion, and then rapidly he had cranial nerve palsy. Seeing double is a feature of cranial nerve, often oculomotor nerve, which is the third cranial nerve. So this is now, it went from a case which can be dealt as semi-cold or cold into an acute case. Okay, this is where the ER, all right, the emergency medicine comes in. And why are we interested in this division? The division lets you know to save life. ER is about saving life. Okay, if you have somebody who is bleeding, you don't go around to diagnose what is the cause of the bleeding. You give blood, replace the blood, because that is the way we save life. If there's somebody who is hypoxic, with difficulty in breathing, his oximeter oxygen saturation was low, you rush to give him oxygen. And then if failed, then you have to put a ventilator. So that's even before to know the diagnosis. So this is we have to check what are the symptoms which need urgent care and urgent treatment. Like in this case, we are going to start treatment even without having the full investigation, because this is now is getting into the emergency type ER. Okay, so confusion is one. If you lose consciousness, if you have confusion, then this is serious. Okay, and this is why we grade them in Glasgow score up to 15, how comatose or how drowsy is the patient. So that is, once he said there is confusion and he doze off meaning that he goes into periods of loss of consciousness. So this young man came with these symptoms, and he was brought to the casualty or to the ER because he had seeing double. And seeing double is something which, the patient will bring himself to it. Yeah. I mean, if you have fever, you may stay 1 day, 10 days, like in his case. But if you have seeing double and you have some nervous system problem, then it's an urgent business. So this is about the symptomatology. All right. Well, the diagnosis of such a case is the diagnosis of somebody who has confusion and fever. Okay, and confusion of fever, like in his case, is you put meningitis first. Okay, if it is a specific organism like in our country, Sudan, we used to have epidemics of meningococcal meningitis. Okay, we used to see so many patients per day in the summer. But once they had the vaccine against meningitis in the Sahel region of Africa, then meningitis came down. But it's still a problem in most of African countries. So that's meningococcal meningitis. But tuberculous meningitis is a very specific type of meningitis because the treatment is totally different from the meningococcal. So the differential diagnosis you put is meningitis, either the meningococcal or tuberculous. And here I tend to say that it is tuberculous because of the duration of illness. He had 10 days. Okay, so he had 10 days on and off. In meningitis, you get acute fever and then confusion straight away. Okay, so this is the line of thinking. But other diagnoses is also important, like cerebral malaria. All right, why is it not cerebral malaria? It may be Marawi is an endemic area of cerebral malaria. Okay, but usually cerebral malaria is in children. Okay, it's a disease mainly in children because of low immunity. Most people who live in endemic countries, they get malaria, but they don't get cerebral malaria. Cerebral malaria is a very lethal, very moribund disease, which can lead to death. Okay, in children. So, and we'll see what is the definition of cerebral malaria. So, cerebral is a possibility. The other possibility is viral encephalitis. Encephalitis is a possibility, not only because of viral, but it can be toxic. Okay, even if you have hepatic failure, you can go into coma or confusion. If you have renal failure, you can go into confusion. So what we say is encephalitis, viral encephalitis, and this is usually involves the whole brain without any localizing signs, without any localizing. Once you have localizing signs, you start thinking about meningitis. This is in general. And another point is cerebral malaria is a is diagnosed according to WHO definition is somebody who is in coma or very drowsy who have a positive parasite in the blood. So if you have malaria positive and you are in coma, according to WHO, you have cerebral malaria. Why is this definition loose? It's very loose because you may have parasite without symptoms. I mean, if you go to the population now and you look into blood films, you can find so many people with parasite without symptoms, especially gametocytes. So why is the definition loose? It is because they want to send the doctors into urgent treatment. Okay, it's overdiagnosing cerebral malaria is even better than underdiagnosing because when overdiagnosing, I start giving quinine, and the patient may respond, may not respond. But when the diagnosis comes in a day or so, the final diagnosis is not cerebral malaria, then no harm, no great harm has been done. If I miss it for 1 or 2 days, then it is lethal. Okay, so this is why sometimes we urge the doctors to start treatment even without diagnosis. And cerebral malaria, if you will, is suspected, particularly in children, you have to start treatment. And this is why the deficiency is loose. Okay, so coming back to this patient, the probable diagnosis is tuberculous meningitis, meningococcal meningitis. He's not HIV positive or negative. If he's a positive case, then you have to think of cryptococcal meningitis as well. Okay, and this has to be considered every time, especially in because the line of treatment is totally different here. This is antifungal, which does not respond to these antibiotics which are using for tuberculosis or meningococcal meningitis. Just give you a story about a patient who came to Saudi Arabia. He's Sudanese. He came about 5-7 days to Riyadh, and he was in coma. Okay, with all the facilities of MRI, CT, PCR, and all the rest of these sophisticated diagnosis. The patient has gone into CT twice, into MRI twice. And Professor Saleh Yassin, rahimahullah, who is an excellent diagnostician, said he was asked to see the patient, and he said, "Did you do a blood film for malaria?" And the blood film was done. It was positive. He was given quinine. In 6 hours, the patient regained consciousness. So these tips will just remind you that not all the sophisticated examinations are always, the answer for our problems in medicine. So think about simple things, all right? For instance, somebody who came with hypoglycemia, okay, he will go into coma. If you don't think about it, the patient may have a damaged brain, okay? So it's which is easy to diagnose. Glucometer, which is usually bedside examination, and treatment with sweets or drip or infusion of glucose, and the patient recovers. So simple things, don't miss it. Don't miss simple diagnosis using simple tests. So this patient has this confusion, this subacute fever, and headache, and headache is a common feature of most of the cerebral diseases. If you have encephalitis, you have headache. Malaria, one of the important features of malaria is headache. Okay, definitely if you have a CVA, you will get headache. If you have brain space occupying lesion in the brain, you will get headache as well. But localization is important. Localization, and here we have third nerve palsy, oculomotor nerve palsy, and this is a localizing sign, what we call localizing signs. It helps us in reaching a diagnosis. All right. The further examination which you should be done, I think neck stiffness, which is Kernig sign, no, neck stiffness is not there. And it's not important to find neck stiffness in every time because it depends on the degree of irritation of meninges. Why you don't flex the neck with meningitis? Because the meninges are inflamed, are irritated, and the patient will cause a spasm. The muscle is going to spasm if you flex the neck. And this is why you get a stiffness. And for the same reason, Kernig sign, which he did not do here, he has to do it, which is you flex at the hips and then straighten the leg on the knees. And this is Kernig. Usually, if it is positive, you can't do that. Okay, it's also a sign in disc lesion because the patient will guard, the muscles will guard the spinal cord not to extend, which causes pain. So he should have done neck stiffness test. It's negative. It's not important, but Kernig sign he did not do. He should have done Kernig sign as well. Okay, and fundal examination. Why fundal examination? Because now there are features of cerebral malaria in the fundus, which are highly specific, highly diagnostic. And these are, whitening in the retina, certain colors are seen. And this is being regained from a lot of postmortem in children, having noted that these changes are in the fundus. So please read about the fundal changes in cerebral malaria. That is important because it's an important examination. Obviously, all patients in coma or very drowsy, you have to look into the fundus because then it's very important, I tell you, because if it's a brain space occupying lesion, you find papilledema. If it's an infection, you can find papillitis. Okay, if it is hemorrhage in the brain, you can find some changes. If the patient is hypertensive and you went into thrombosis, then features of hypertension and diabetes, which is precondition for cerebrovascular accident, is seen. So this is important to look into the fundus in such cases. Okay, obviously here there is no credit for not doing the cranial nerves, the rest of the cranial nerves to see where the localization is. Okay, those diseases are the important bit. So this patient is in ER, okay, and he is comatose. We have to select tests which will tell us very quickly what is the problem. Okay, depending on the site where you are, you can do some tests which are very rapid and very important in as far as diagnostic yield is concerned. Anyway, I have the results of this patient. He has white count. I don't know if I mentioned it in the answer sheet or not. He has a white count of 3.2. The reference is 4 to 10, and this is per liter, all right, 10 to the 9 per liter. Hemoglobin is normal, again, gram per deciliter, 10.2, which is normal, 12. The normal is 12 to 14. And glucose is important here. I tell you why in a minute. Because glucose here is millimoles per liter. I don't know if Tanzania and Rwanda are using the millimole, but let us stick to the international international levels, which is millimole per liter is 4, and the normal is 3.9 to 11. So his glucose is normal. Okay. The diagnosis of meningitis was sustained. Another diagnosis, which is not a feature here, but has to be considered subarachnoid hemorrhage. Okay, another cause of meningeal irritation is subarachnoid hemorrhage. All right, this is either perianeurysm, which can occur in young people, okay, or a leak from cerebral hemorrhage, okay. But in young person like this, perianeurysm, which is usually congenital, can leak into the subarachnoid and can give you meningeal irritation, not as much as headache. Well, headache is very, very, very severe there, but not as much as fever is concerned. But the rest is meningeal irritation can be easily seen in subarachnoid tumors. So this patient was diagnosed provisionally as somebody who had meningitis. We don't know what is the type, but we favor tuberculosis because of the duration. And CSF was done immediately. Here, CSF is the important diagnostic test which should be done as soon as possible. Let me just um, remind you of some of the important aspects of doing CSF examination. Okay, it is done between level 4 and 5, L4 and 5, or if you are somebody is obese, you can't count the things, the vertebrae. You can have the iliac crest, the level of the iliac crest, and draw a line to the other iliac crest across the back, and where it hits the vertebrae, that is the area of where you push the needle. We push the needle in an empty, not empty, but no extension of spinal cord there, because otherwise we don't want to hit the spinal cord. And if it's called equine, because this is leafy, we don't. There is no harm to the quad equina. So it's that is the place of. It's important to have it in the right place. It needs some experience. And I encourage you, if you have mannequins, to try and do the lumbar puncture, observe what people are doing as far as lumbar puncture is concerned. And I hope some of you will have a chance, even before graduation, to do lumbar puncture, because this is an important, not only in the acute stage, but even in the chronic stage of neurological abnormalities. So the danger of the lumbar puncture is somebody wants to point something. Fatma Salahuddin? No? You still with me? Hello?
Yes, we're following, doctor.
Okay. So it's if you do a traumatic lumbar puncture, you have blood, and this is unfortunate, because if you don't do it well, you have blood because of the trauma. Okay. In subarachnoid hemorrhage, the diagnostic CSF is blood stained. Okay. But if it is traumatic, how would I know this is traumatic and not due to a bleed in the circle of Willis? The answer is you take 3 tubes. 3 tubes successively, about 1 or 2 cc's, mils of CSF, 1, 2, and 3. If the blood is consistent in color, then this is most probably subarachnoid hemorrhage. If it dilutes in the third tube, becomes paler, then it is traumatic. It is from you. And if it is traumatic, you lose the value of CSF. If it is traumatic, you lose the value because you have blood here. And if you have blood, you have white cells, you have glucose, you have proteins. And as we are going to see, the most important 2 aspects is not the color of the patient of the CSF, the white cells in the CSF, the proteins in CSF, and the glucose. And this will get messed up if you have traumatic puncture. So it's very important to learn how to do a good lumbar puncture. Okay, it has no danger. All you need to do is rest the patient. Okay, he may have a slight headache. All right, we don't take too much of the CSF, but he might have headache. If he rests for the rest of the day, that will be enough. Okay, so it's relatively safe procedure. So learn how to do it because it's important. Okay, coming back to this patient, the CSF was done. Luckily, we look into the color. As we said, if it is blood stain, we knew how to differentiate. Then it may be clear, and you may have even viral encephalitis. The CSF will be clear. In cryptococcal meningitis, which is HIV related, again, the CSF may be clear or even normal as far as other parameters are concerned. So this patient had a CSF. It was turbid, sometimes in meningococcal meningitis, it can be normal CSF. The color is important, but if it is positive, it is more important. Sometimes it's turbid, meaning that there is infection somewhere. And in meningococcal meningitis, I have witnessed myself CSF coming out as pus, as purulent, and this is diagnostic. So you could have clear CSF, a bloody stain CSF. You can have a clear CSF or turbulent or purulent, and changes can occur with different colors. All right, but importantly, we should look into cells. All right, in the white cells of the CSF. And this patient, as far as his record is concerned, they tell me that it is 54 cells per microliter. A micro is 1/1,000,000. Microliter is 1/1,000,000. Okay, it's written like this. Okay, come like that. Okay, microliter, and it is 54. And the upper limit of all cells that should be in microliter in CSF is 5, 0 to 5. That's the maximum. Otherwise, there is inflammation. And the type of cells is important. If it is tuberculous, then it is lymphocytes. If it is meningococcal or other bacteria, it is polymorphs. Then the other parameter, which is I have here in front of me, is the protein. Okay, very important. And protein here is 3 grams per liter, and this is very high, almost like 6 times high from the upper limit. The upper limit is 0.25 to 0.55. Okay, it's less than 1 gram, half a gram, from quarter of a gram to half a gram. That is the normal, and this patient has a very high protein. In meningococcal meningitis, you get high protein, but not as high as this. In tuberculosis, one of the parameters of diagnosis is protein in CSF has to be more than 1 gram, and this is very indicative of tuberculosis. And then blood glucose. Blood glucose always low in cases of meningococcal or tuberculous meningitis. All right, it is usually normal in viral meningitis. This patient has a millimole per liter, 1.3, and the normal is 2 to 2.64. So he has a very low glucose. And we usually relate the CSF glucose to the blood glucose, okay? And it has to be less than 50. The CSF has to be less than 50 of the serum or blood glucose. And in this person, I think I didn't calculate it, but it may be like a third or just over a third. So it is less than 50, which is okay. But more important is very low. More important, the proteins is very high, and this is almost favoring very high tuberculosis. The proof of the pudding in the eating, as the British will say. So here we cannot say, we swear that this is tuberculosis unless we recover the acid-fast bacillus from the CSF, and this is not usual. It's not usual to find acid-fast bacillus, very rare, all right, to find it, but it can be recovered, okay? We can send CSF for gram stain, and this will indicate meningococcal meningitis. But their Nielsen stain for tuberculosis is often negative, but it can be positive. If it is positive, or the culture turned out to be tuberculous bacilli, then that is the proof. I can swear to God that this is a patient of tuberculosis. But otherwise, it is presumptive, high presumptive that tuberculosis. Okay, there is now A very sensitive PCR, which I think I mentioned in the answer, the high PCR, very sensitive PCR for detecting tuberculosis in the tubercle bacilli in the CSF. It's the expert TB that test, which is, there is a cartridge now, which is bedside. You can easily do it at the bedside and very highly sensitive to tell you if it is tuberculosis or not. So with that, I think tuberculosis can really be ascertained that this case is tuberculosis. Well, as far as cryptococcal meningitis, which is another differential diagnosis, we do cryptococcal antigen in the CSF. And again, this is available, which is very useful for cryptococci in the CSF, cryptococcal infection in the CSF. So this is what it is. So what happens in, how would a patient get all these symptoms from tuberculosis? All right, the granulomatous, the granuloma in the subarachnoid area get ruptured. And if it is ruptured, exudates, thick exudates will trickle down the subarachnoid space. What happens is that it can block the circulation of CSF, and patients get hydrocephalus. And actually, if you do an MRI, you can see a degree of hydrocephalus in these patients. This is why early on with the fundus, I asked you to look into the fundus of these patients. So that is number one. Number two, cranial nerve palsy. Meningitis is very known to cause cranial nerve palsy. More often in tuberculosis than meningococcal, but in meningococcal, there is a certain degree of meningitis, of a certain degree of cranial nerves. And I have seen children who just recovered from meningococcal meningitis because it was a delayed diagnosis. I remember somebody, a child whom I have shown sometime in the TV, برنامج صحتك, is a child whom I knew his father, who had been going to a hospital there, and he was missed as a meningococcal meningitis, okay? And then he ended with eighth nerve palsy, deafness, he became deaf, and a child who used to talk, like a singer, okay, suddenly lost his power of his speech. So if you lose a child, if you lose your hearing, you lose your speech. So that is a message which I always remember, that the delayed diagnosis of meningitis of any type, then you lose the patient's cranial nerves. And if you lose one or two in childhood, then the effect is devastating or very high. So cranial nerves these exudates in tuberculosis can block some of the nerves and can cause cranial nerve palsies. So this is the exudate which comes out of the granulomatous tissue, which ruptures in the subarachnoid space. Treatment. Okay, this patient, if I see him in the ER, while the CSF is being looked at, I will treat him for meningococcal meningitis and tuberculous meningitis at the same time, okay? Suspecting cryptococcal meningitis, then this is another thing, it's an antifungal. But here, we are not suspecting HIV, so cryptococcal meningitis is slightly out. So the treatment here, we catch the meningococci by ceftriaxone, which is the third generation cephalosporins, 2 grams per day, ceftriaxone, 2 grams per day. And then I add 4 drugs of tuberculosis or anti-tuberculosis drug. These are rifampicin, which is an antibiotic, INH, which isoniazid it. This is very specific to tuberculosis. Rifampicin obviously is an antibiotic, can be used in cholangitis, or very good for cholangitis. But here, we would like to reserve it for tuberculosis for fear of resistance. So rifampicin, isoniazid, ethambutol, and pyrazinamide. The duration has to be minimum of 9 months, better 12 months. Okay, so once we get the results of the CSF and it is confirmed that this is tuberculosis, okay, we can stop the antibiotics and then carry on with the tuberculous meningitis treatment or anti-tuberculous drugs. This way, definitely. Otherwise, if you just treat a case of tuberculous meningitis as a meningococcal meningitis, you are not treating the patient, and the patient will get complications and may even lose his life. So it's important that between these two, you get a final diagnosis. So this is a patient who ended up as a case of tuberculous meningitis, which is important. But then we have leisure of time to do other tests. Why did he get tuberculosis? Is there family history? How about the chest X-ray there, to see if he has any signs, cavitations, fibrosis, consolidation. All this may be signs of tuberculosis. And then a good follow-up of this patient for fear of neurological deficit. It's very important to continue seeing this patient for all this time to minimize any complications. Okay, so that is the case of tuberculous meningitis. I hope it's been clear. We have reviewed quite a bit of the tuberculosis, meningitis as a whole, and encephalitis, cerebral malaria, and then the definition between ER and cold cases. It's important to always keep it in mind that you have to hurry in cases of ER or symptoms of ER versus subacute or cold symptoms. The treatment is important. If I can just give you some side effects of the anti-tuberculous drugs. Number one, rifampicin is called the red drug. The rifampicin causes, red sweats, red tears. Okay, and we used to have a professor who calls it the red drug. Anyway, it's not. It's quite acceptable and quite patients tolerated. Okay, isoniazid, apart from the GIT, which I'm not going to concentrate on, is it can cause peripheral neuropathy in patients who are slow acetylators. Okay, peripheral neuropathy who have slow acetylators. As you know, a population is being divided into two: those who are fast acetylators, okay, and those who are slow acetylators. What is this? This is enzymes in the liver which acetyl transferase. This is the enzyme. Sometimes it is low, sometimes it's high. If it is low, you are a slow acetylator. If it is high, you are a fast acetylator. Meaning what? If you have sulfonamide, dapsone, these are the drugs which are acetylated in the liver, okay? And isoniazid is acetylated in the liver. So if you are a fast acetylator, you chop these drugs very quickly, okay? And if you are slow acetylators, then the drug will remain in the blood for quite a while. So if you are a slow acetylator, INH may cause peripheral neuropathy. And this is why we give B6 with INH, okay? But if you are a fast acetylator, INH can cause hepatitis. Okay, and this is also a case in rifampicin. Rifampicin can cause hepatitis. So you have two drugs which can cause hepatitis, which are given in tuberculosis. So if you have hepatitis, you wouldn't know which is causing the hepatitis. You stop one and see if it resolves, and then you stop the other if it resolves, and so on. But usually this is, thanks God, that is not very, very limiting to the use of these two drugs. And then ethambutol. If you want to remember ethambutol, the most important thing is fundal examination, because it was cause narrowing of the field of vision. Okay, pyrazinamide is notoriously known in the MCQ questions as a drug which causes hyperuricemia. Okay, if you have gout, you take pyrazinamide, then your gout will be worse, and you get pain in the first tarsometatarsal joint. So that is these drugs, and we are lucky. We are living in an era where drugs for tuberculosis are still relatively safe and are given free. As I said in the last lecture, that the Global Fund, which is an international fund, provide drugs like anti-malarial, drugs like for HIV, AIDS, and drugs for tuberculosis, all for free for countries which can prove that they can use it rationally and wisely. So that is what brings me to this case, and I hope this is going to be all right for reading more about tuberculosis, about tuberculous meningitis, about encephalitis, about cerebral malaria. Next case, I will send it to you. I will write it now, send it to you, to send it to the leaders, they can be distributed thereafter. Give you a few days to look into it, and please try. Please try. We are not asking you to do the abnormal, but it's one page. If you look into it, if you think about it, if you write your answers, then you will benefit from a discussion of the case. But if you don't see it, if you just look at it at the time when the next lecture is there, you lose. The discussion will not be as fruitful, as useful, as if you have read carefully the case and you have tried answering the questions there. I wish you the best of luck, and thank you very much indeed for being with me.
Thank you so much.
Any questions? Anybody has any questions? We still have 3 minutes. Ruba.
No, thank you. Thank you so much.
And the rest of the students, are they there?
Thank you, Doctor. Thank you, Prof.
No
Thank
questions.
you,
Okay, thank you very much indeed. Keep well, and I will see you. I'm in Dar es Salaam now. Thank you very much indeed. Bye-bye.